I would like to invite Rishikesh to give a brief introduction about both our speakers. Rishikesh, I think I am audible, Rishikesh.
Yes, yes, yes. Thank you so much, Abhishek, for giving me the opportunity to introduce the sessions. And okay, thank you, everyone. Dr. Shane, Dr. Uh,
Dinesh Sumta, sir.
Roomta sir. Sorry, my bad. So, right. So we have to talk into today's sessions. So our first speaker will be Dr. Shobik Shen, sir. I'd like to briefly introduce sir is like a young energetic person from Susrut. Sir has completed his done his fellowship from Susrut only in vitreoretinal surgery, and today evening sir will take us through the presentations differential diagnosis of PCV and distinguish between AMD and other retinal conditions and the management. So over to you, Shen sir.
Yeah, very good evening. Am I audible to everyone?
Yes sir, yes.
Okay. Thank you very much. Very good evening to everyone. I'm Dr. Souvik Sen, vitreoretinal consultant from Sushrutai Foundation. So I'll be presenting diagnosis of PCV and distinguishing between AMD and other retinal conditions. But the main focus of this presentation today will be actually on what other diagnostic modalities can we explore efficiently in addition to the gold standard, given the geographic reality that we live in today. So when you look at the prevalence of PCV among neovascular AMD eyes, it's much higher prevalence in Asians and Caucasians. And it begs the question that if it's higher in Asians and Caucasians than in Caucasians, do Asians have uniformly have more access, better access to the gold standard diagnostic tool, which is ICGA, in all geographic locations. So Asian countries, they don't have that uniformity and the feasibility for accessing ICGA in order to effectively screen and diagnose IPCV in patients with neovascular AMD. So
Sir,
it begs the question,
Sir,
can we
sorry
have...
to interrupt.
sorry, sir. Sorry, sir,
Right.
interrupting you. Your slide and your video is not visible, sir.
I think I've shared it. One
No,
second.
sir.
One second.
Now
Now,
it's coming, sir. Yeah,
yeah. So,
kindly open your video, sir.
yeah, this is the... Okay, one second. One second. The videos... Yeah, if I'm playing this, the slides on, right?
Right.
Yes, so
Is
I
one,
can...
but we can see your face, sir. Your
Yeah.
face
Now
is off.
there is a
Okay.
Right.
Yeah, one second.
yeah video sign is there, sir. Just click on it.
One second. Back to meeting. One second. Just a minute. It's not...
Their tech team kindly help out our doc speaker.
Going back to the meeting, it's not really... One second.
Uh, Tech team is there. Hi,
Yes,
tech team.
yes,
Yes,
sir. Yes, sir.
kindly help Dr. Shobik Sen to start his video.
Uh, Sir, you are using an
I'm
iPad?
going back to the meeting. I'm going back to the meeting. I'm clicking
Yes,
back to the meeting, but it's not...
sir, you are using a tab or a MacBook?
Yeah, over MacBook.
Okay. So you have to press command and
Right? Command and
uh, tab.
command and
Tab.
tab.
Yes.
Okay. So it's gone back to the join. One second. But it's gone back to this again. Oh,
You have to minimize the PPT first.
yeah, just Video.
Just double click.
Yeah. Yeah, it's minimized. I think the PPT is minimized. It's not, is it still sharing?
No, no. Yes, sir. It's your slides is set
Yes, style is visible, sir. Yes, sir. 90%.
visible. Yes.
So you want me to unshare it first? One second.
Just a minute. I'll send you the request. You get the request. Start camera.
Yeah, start my video. Yeah.
Yes. Okay.
Okay.
Yes, sir. Yes, sir. You are now.
Now
Uh,
it's fine?
Again,
yes,
it has.
sir.
Yes, now it's coming, sir. Now
Okay, thank you. So this is just the second slide. So we're talking about the prevalence being higher in the Asiatic region. We're looking for other diagnostic modalities that can help us substitute the gold standard, which is ICGA, with the same sensitivity and specificity, which I'll come to later. So indocyanine green angiography, as we know, is the diagnostic gold standard, but it's an invasive procedure, which means it comes with its own set of potential acute and non-acute implications. And it's also a time-consuming process, not to mention a costly process also. So what are the other imaging modalities that we can think of? There's color fundus photography, there's optical coherence tomography, there's fluorescein angiography, there's fundus autofluorescence, and there's OCT angiography as well. But zeroing in on what's really important, we're looking at OCT in the diagnosis of IPCV, and along with color fundus photo, because these are very widely available. So how does this work? If we look at a picture of IPCV on a color fundus photograph, there are certain things that we instantly notice, certain characteristic clues. We see subretinal orange-red nodules. We see fibrovascular PED areas, which we have to obviously confirm with other imaging tools. Then we see massive subretinal hemorrhage. We might see massive subretinal hemorrhage. We also may see a peripapillary location of the lesion, and not necessarily any large drusen. But I'd like to share the next two slides are actually the most important for this presentation, because they set the tone for what we're about to see. If we look at each imaging modality, each one has a set of diagnostic clues that actually help us go towards a diagnosis of IPCV. So, for example, as I showed you, color fundus, we have subretinal hemorrhages, sub-RP hemorrhages, orange subretinal nodules, serosanguinous PED. For OCT, we have thumb-like sharp peaked PED, hyporeflective lumen in the PED, double layer sign subretinal fluid. Octa, we have branch vascular networks, and then comes the gold standard, which is ICGA, where we can see the nodular hypofluorescence, polyp pulsation, hypofluorescent halo. But I'd like to focus on the last column, because what we have to understand is each of these modalities in the hierarchy of diagnostic tools, they have a certain value. ICGA, as you can see, gives us a diagnostic confirmation. So it's right up there at the top level. In a close second is the OCT, which is strongly supportive. It might not be as confirmatory as ICGA, but it is very strongly supportive. And of course, when we look at color fundus photo, it is only suggestive. Now, the real question here is, if we don't have access to ICGA, or if there are barriers to accessing ICGA, can we combine any of the other two? For example, something that is strongly supportive with something that is perhaps suggestive, to approach the sensitivity and specificity of something that is like gold standard like ICGA. So let's explore that, because there are studies that have been done on that. Now, if I just look at it at a glance, OCT and color fundus photo, they have their, if we use it in combination versus ICGA alone, it has its own set of advantages. First of all, it's non-invasive, acute, systemic, and non-acute implications. Obviously, there's a list of that. Those will not be there. It's more comfortable and acceptable to the patient. It's widely available, lower cost, better cross-sectional resolution and detail, which you can't get in ICGA, excellent visualization of morphology, monitoring, follow-up is much easier. The retinal workflow in the hospital, it becomes much easier, much more convenient, and there's a clear visualization on color fundus photo. You can actually show the patient the photo. And of course, again, the workflow, outpatient imaging, it's more ergonomic also. So coming to that, let's look at, of course, optical coherence tomography for diagnosis of PCV. There's lower cost, and how do we use this to generate the same kind of sensitivity and specificity when we're confirming diagnosis. So there's certain hallmark features. We look for notch PD. We've seen so many of these in the outdoor. We look for peak notched or peak PEDs. We look for hyperreflective ring under the PED, and we look for a double layer sign. So how can we use these criteria now, and where can it lead us? So there are studies that were done. I'd like to focus in for zero on the DeSalvo study, where they only used OCT alone for the diagnosis of IPCV. And what they found was that it had a if we looked at these criteria, multiple PED, sharp PED notch, hyperreflective ring beneath the RPE, and we used three or more diagnostic criteria, it led us to a sensitivity of approximately 95% and a specificity of 93%, which is astounding. But it gets even better, because if we combine this now with color fundus photo, add this into the mix, now we are approaching, they did a retrospective imaging review. Now we are approaching 95% sensitivity and 95% specificity. So combining these two, we're approaching the sensitivity and specificity of diagnosis that we could get with ICGA. So this is what we're looking at a patient potentially who may be having IPCV of the neovascular AMD subset patient. If we suspect they might have IPCV, we might be seeing this in the fundus. And then on the OCT, of course, we'll see a sharply peaked PED with angulations between 70 to 90 degrees. Then we're seeing PED notch or multilobulated PED. So this is a very characteristic finding. And then we're seeing that characteristic hyperreflective ring underneath the PED. So when we combine these characteristic hallmarks, it helps us arrive at that diagnosis more confidently. So now, so they did a study using these modalities on patients who were white Caucasian patients, but the one group was Hispanic and one group was non-Hispanic. So the study was actually a multi-center retrospective imaging review done in 9 centers around the world: Europe, Mexico, Australia. So what they did was they selected 197 patients with neovascular AMD, not patients, but eyes with neovascular AMD, and they tried to screen them using a combination of OCT and color fundus photo and the criteria that I mentioned to screen out the patients in this group who might have IPCV. So what they did was, first they confirmed the neovascular AMD diagnosis using color fundus photo, OCT, and fundus fluorescein angiogram. Then they used only color fundus photo and OCT to find out which patients among them had a IPCV diagnosis. So what they found out was that actually 23%, 23.4% of that entire group turned out to have a PCV. And among the 46 eyes with 2 or more features, 61% had at least 2 features, 28% had at least 3 features, and 11% had at least 4 features. So it showed, and this is the data for individually for Hispanic whites and non-Hispanic whites for PCV: 10.9% for Hispanic whites, 89.1% for non-Hispanic whites. And they conducted the same study in Australia. Now, in Australia, when they did this, they just did it with OCT alone. They didn't even use color fundus photo. So they just focused on the OCT criteria, the characteristic OCT criteria, which are multiple PD, sharp PD, peak PD notch, hyperreflective ring. And again, they arrived at 95% sensitivity and 93% specificity. And they found that 22% of the eyes with neovascular AMD turned out to have PCV. So that was a very important thing. Now, coming to Okta, there's not much I have to say on Okta here because it's not widely available, and we're focusing on imaging tools that are more widely available that can be used. But it's important to say that when we're taking the slabs, the chorioretinal capillary and the RP Brooks membrane slabs, we're looking at the end-face imaging, the M-face image, and we're looking out for branch vascular networks, because the presence of branched vascular networks actually gives us a clue about activity, the presence of activity. It helps us plan for further injections and the regimen for further injections, or to help us decide whether we should inject or not. So coming to this, what are the potential benefits anti-VEGF therapy can provide with patients in addition to visual acuity gains? Now, of course, when we're treating these patients, along with functional gains, which is visual acuity, there are other things we would also like to achieve. So, functionally and also anatomically. So we want complete polypoidal regression. We also want a total reduction in the number of polyps, and we also want to see a complete remission of activity. We don't want activity. So we want polyps to regress. We want them to at least reduce as much as possible number. We want the activity also to reduce, which is, usually marked by the presence of fluid. So now, in the PLANET study, which was a randomized phase 3 double mask study that was carried on over 52 weeks, 1 year, to determine the effectiveness of aflibercept. So, what they found was that along with substantial visual gains, more than 80% also showed no evidence of polyps at week 52, which means even the active polyps had regressed. So, this was very important. And it's important to also mention why active regression of active polyps is important, because if you have, let's say, functional vision gains but there are still polyps there, then what happens is the recurrence rate actually increases, the number of injections you will need to give, that also increases, and the intervals between injections reduces. So this was actually found out in a Japanese study. So they use a treat and extend regimen for of aflibercept for over 2 years. So complete polyp regression group, what they found out was that there was a less recurrence rate, less number of injections, and longer treatment intervals which they could extend to. So it's very important to look at polyp regression and activity also along with functional gains. So now, how long do polypoidal regions remain regressed on ICG after initial inactivation? So let's say we are to inject with a loading dose of 3 monthly injections. Now at week 12, at the end of it, if we are to look at it, there are two groups. One group they will regress. The polyps might completely regress. In that group, we defer the treatment with a monthly OCT for 1 year. And in the second year, we go for a bi-monthly OCT. Now, when we do this, there are two possibilities. Either that results in no disease activity, or if this disease activity is still present, we continue monthly injections until the fluid is resolved. But the question is how many injections at what intervals? This actually depends on the level of activity that we're getting. So even if we are continuing injections, we have to gauge the level of activity to determine how many and at what intervals. And if we are spacing it out at intervals with a treat and extend regimen, then we have to look for, we should not go beyond 16 weeks. The criteria is 16 weeks is the maximum interval between two injections that we go to. And again, we determine at what point the polyps have totally regressed. From that point up to the end of the second year. So that is the interval we're looking at. Now, the second group who had received a loading dose of 3 injections, they might have partial or no polyp regression. So in that case, we add another dose of 3 monthly injections. So if we do that, then it comes down to two groups again. Either there'll be a complete polyp regression, in which case we go back to the former protocol of deferring treatment with monthly OCT in the first year and bi-monthly OCT in the second year. Or the second, if there's a partial or no polypoidal regression, which means there's a high chance of activity, then if there's activity, then we have to again assess what is the level of activity. Should we continue monthly injections or should we treat and extend? And if there is no activity, we still have to wait and watch, and we may continue injections, but at much larger intervals. So these are two groups. So it comes down to whatever, if we choose to extend treatment, the maximum interval that we're looking at over this period is up to 16 weeks. And what we're aiming for is not just reduction of activity, complete cessation of activity. We want polypoidal regression also. So to sum up my presentation, ICGA remains the gold standard for PCV diagnosis. However, alternative imaging modalities can be used to diagnose PCV where ICGA is not available. ICG is not readily available. Features of color fundus photo and OCT can provide high sensitivity and high specificity, as the many varying studies showed in detecting IPCV. Alongside achieving clinically meaningful visual gains, aflibercept monotherapy can achieve complete polypoidal lesion regression as early as month 2 in patients with IPCV and can achieve high rates of polypoidal lesion inactivation. So these findings support consideration of aflibercept for IPCV to achieve both anatomical and visual outcomes. Thank you very much.
Thank you so much, sir, for the insightful presentations. So we are open to take any questions, any doubt from audience, I think. So is there any doubt? I think in chatbot we got on questions. So how many loading dose do you give in like in clinic, actually in clinical scenario for the PCV set usually?
So PCV, the loading dose, we'll start off with 3 monthly loading doses, and IPCV is, aflibercept has been the safety profile has been very favorable. So if I need to treat and extend, I don't hesitate in that scenario. But of course, now I'm more increasingly using OCT angiography to gauge signs of activity and along with a B scan OCT image. So and of course this has to be coupled with the functional visual gains also. So it's a 3 monthly loading dose that I use.
Right. So I think it's quite justified. So any questions from any other audience
Great
or
presentation, Dr. Shovik Sen. So I have one question. Like,
Mhm.
have you faced any kind of RP rip after loading dose or after any injection in case of PCV? Because the PED height is very tall and it may lead to a RP rip. So have you faced any in your daily practice?
So when it comes to very tall PEDs, though, that's the likely circumstance where one could face an RP rip. So I think the rule of thumb there is to use a therapy that doesn't cause rapid decline in the height of the PED, too rapid, too instantly. And I think aflibercept has actually worked very well in that situation. There are other anti-VEGFs that give very quick results, but the decline of the PED is so rapid, it can induce an RP rip. There are. So, as a time-tested treatment modality, I think aflibercept is one go-to therapy that, has helped me. And more than there is in the case of tall RPs, more than what the visual outcome and the reduction in activity, I'm more concerned about the RP rip. So even if I have to use something that might not give as rapid functional and anatomical gains, I don't mind because I don't want a rapid decline in the height of the PED so that, it actually it's safer in the long run.
Thank you. So I have another question for those resistant cases. Like we have all faced some resistant IPCV cases in our clinical practice. Like with the help of aflibercept, I have faced what 90% of the patients have good vision and regression of the polyp, but those 10% who didn't respond or there is recalcitrant fluid presence. So do you prefer brolucizumab in those cases, or do you keep on giving the aflibercept?
Well, with brolucizumab, the one thing that I'm always when I look at the OCT image, particularly the B-scan OCT image, I'm actually more worried about rapid scarring in that region because it works very fast. So it depends on how advanced I look at the visual acuity in the case of brolucizumab because what happens is uh, in terms of OCT biomarkers, it may seem to work very quickly, very rapidly, very strongly. But then what you don't want is rapid scarring and the patient to actually lose 1 or 2 lines of vision. So yeah, I may consider brolucizumab, but then it depends on what I'm seeing in the OCT along with what are the visual acuity because I don't just look at if you've given a loading dose of let's say aflibercept and it's been resistant, I'm not only looking at the non-responsive OCT, I'm actually looking also at how the visual acuity has changed over that period. So I tried, it's subjective from case to case, but yeah, I mean, I don't have a hard and fast rule that I will shift to brolucizumab in that situation because there are other pitfalls in doing that. So that will depend on what I'm seeing the OCT and what are the visual acuity gains, or has it been stable? Has the visual acuity been stable or not? It also depends on that.
Thank you so much. So I have last question for the panelists, like all the experts are present here. Like, do you have any experience for 8 mg aflibercept in your clinical practice?
Not in India.
Yeah, so I'll take that query, sir,
Studies,
because
the
as
study is
it
going
is,
on, so I think it's not in India approved right now, right?
yeah,
Till now, it is not available in India, but we are
Hmm.
expecting that in the month of July, August, we are going to launch in India with the Aplivasive higher dose 8 mg.
Yeah. आगे study शेष होते तो
Dinesh sir, I would like to hear anything. So one like PCB and the last presentations. Have you any interpretations? Like, do you prefer like complete regressions or polyp inactivations? Rather inactivations if
yeah.
the BCB again
So
is
the
there.
answer, then you will get the answer of your question from my after my presentation.
Sure, thank you so much. So, if there's no more query, we can move to the next presentation, I think, with Dinesh sir. So, to introduce sir, sir is from Disha Eye Institute. Sir has done his fellowship from Giridhar Eye Institute, and sir is currently practicing in Disha. Sir will take us through the presentations, the differentiating between fluid compartment in clinical practice. Over to you, sir.
Okay. Yeah.
Thank you.
So is it my slides are visible?
Yeah, absolutely, sir.
Yeah, now it's
Okay. Full screen, okay?
no, and now it's coming to full screen. Yeah, now it's
Yes.
okay. Now it's okay.
And video on করে রাখবো তো অভিষেক?
Video on করে দিচ্ছি।
Okay. So thanks for the lovely introduction. So the topic is differentiating between fluid compartment in clinical practice. So, so he has asked a very good question, and let me complete my presentation, then we'll reply. So the role of the fluid and its impact on the vision in the retinal condition. So we should understand the implications of the individual fluid compartments may be critical to guide treatment decision to optimize treatment intervals. So we all know that in whether it is DME or whether it is neovascular AMD, interretinal fluids, subretinal fluids, subarachnoid fluids. So different kinds of fluids. So what are their importance and how it signifies? Okay. So we should know that effective management of the fluid in neovascular AMD is crucial, and studies indicate that the
Sorry, sir.
Sorry?
I think your slide is not changing, sir. I think.
আমি স্লাইড চেঞ্জ করিনি অভিষেক
Okay. Disclaimer slide না, disclaimer slide কি রয়েছে? Okay, fine.
ডিসক্লেমার স্লাইড হয়েছে
হ্যাঁ।
না এটা তো এসেছে দেখো আসেনি
Now it's okay, sir.
Now it's
okay, maybe little bit of network issue. Okay, so role of the fluid and its impact on vision in retinal condition. Effective management of the fluid in neovascular AMD is crucial. Studies indicate that the IRF negatively impacts visual outcomes, whereas subretinal fluid is linked to better functional visual outcomes both at baseline and during treatment. And this will come to know with the help of the different studies which has already been done. So coming to the VIEW study post hoc analysis, and it suggests that in a proactive treatment setting, overall retinal fluid does not have a marked impact on vision gains in patients with neovascular AMD. So basically, from this PPT, what we going to understand that overall fluid status, if we add all these subretinal fluid, interretinal fluid, subarachnoid fluid, so overall fluid doesn't have so much impact rather than the individual fluid impact. So what they want to give importance, whether it is SRF or whether it is IRF, which one is good, which one is bad. Okay. So here from the bar chart, and we can see that BCV change is hardly significant in the persistent dry and non-persistent dry neovascular AMD, and overall retinal fluid status is also not so much significant. So it suggests a disconnect between an anatomic and functional outcomes in the patient with neovascular AMD after initial monthly doses. So therefore, overall retinal fluid as a marker for visual outcomes may not be appropriate. And that's came the role of the different fluid compartments. So we all know, so there is an presence of the SRF in the absence of the IRF is typically associated with good visual outcomes, whereas presence of the IRF associated with the poor visual outcomes. And the role of the sub-RP fluid is still elucidated, but it has been linked to poor visual outcomes if correlated with the fluids in the other compartments. So this is a very important study. We all know that the fluid study, in the prospective fluid study, which here the ranibizumab treat and extend protocol that tolerated less than 200 microns of the SRF led to visual outcomes which is comparable to those when treatment aimed to resolve all SRF completely. So this is a very important study which given the significant summary that little bit of SRF is still tolerated and associated with a good visual outcome. So we don't have to need to resolve all the SRF in a case of the neovascular AMD. So this data highlights, so here we can see there is a two groups. One is the red one is the intensive treatment and the green one is the relaxed treatment. In the intensive treatment, we are resolving the all SRF. In the relaxed treatment, we can leaving the 200 microns of the SRF. So if we see that the number of the injections and at the end of the 12 month and 24 months, proportion of the patients gaining the 15 letters are almost non-significant. So all this data highlights that aggressively chasing SRF is not associated with the functional vision benefit to patients in the neovascular AMD. Coming to the VIEW study, post-hoc analysis, it also says that the patients with the early persistent IRF had significantly lower vision gains than those without early persistent IRF. So here we can see in the middle of the graph related to the IRF status. So at the week 24, mean change in the BCVA is quite significant. So that's came the role of the IRF. So eyes with the persistent or residual intraretinal fluid have shown to a significantly lower vision gains than those compared to the without IRF. So what we want to say, but in a case of the neovascular AMD, intraretinal fluid is a poor visual outcome. In the VIEW study, despite greater resolution of the SRF with aflibercept than with monthly ranibizumab, there were no difference in the visual acuity at week 52. So here in the graph, here we can see in the midpoint, here the square box has been done at the week 52, that is at the end of the 1 year. If we compare the ranibizumab arm with the aflibercept arm, it's almost non-significant. So what summary we came to know that the greater resolution of the SRF with aflibercept than with monthly ranibizumab was not associated with difference in the visual acuity gains at the primary endpoint, which evidence that residual SRF may not have a negative impact on the functional visual outcome. So all these studies, whether it is Harbor, whether it is Altair, whether it is VIEW study, all this wants to say a simple thing is that intraretinal fluid is not good at all for the neovascular AMD. Here in the Harbor post-hoc analysis, they are saying that whether it is month 12 or month 24, the difference in the BCVA between the residual IRF and resolved IRF is quite significant. Where it is in subretinal fluid is not so much significant. Same in the CAT study, here we can see post-hoc analysis, 5-year analysis, that the presence of the residual IRF is detrimental to vision, whereas residual SRF is associated with a better visual outcome. So here we can see in the left-hand side, so this arrow is going down from baseline to year 5 if the presence of the IRF is there, and whereas in the right-hand side here we can see that the arrow is going up. So visual acuity in the patients with or without SRF is not so much related. So 5-year post-hoc analysis highlights that the presence of the residual IRF is very much detrimental to vision, whereas residual SRF is associated with better visual outcome. Abhishek, slides are visible, right?
Right, sir. Right. This is
Okay.
absolutely
So
fine.
same, so same in the post hoc analysis from the view study. It also says the same thing in the left hand side of the IRF bar chart. In the right hand side, the subretinal fluid bar chart. Here we can see that the arrow is going down if the IRF is present, whether it is a week 24 or week 52. Whereas in the SRF, it's not so much related. Same in the post hoc analysis from the Altair study, 2-year post hoc analysis. Foveal interretinal fluid was associated with worse visual acuity, whereas residual SRF was tolerated. So, how this fluid guide the implementation of the individualized treat and extend with aflibercept for patients with neovascular AMD in our routine clinical practice. So, in the aflibercept treat and extend protocol, treatment is initiated with 1 injection per month for 3 consecutive doses, and the treatment interval is then extended to 2 months. So treat the patient until it is stable, and once it is got stable, then we have to extend the interval to 2 months. And then afterwards, we will continue to extend the patient until the fluid recurs or the visual acuity declines. And once it is decreased, so interval to previous stable, we have to decrease the interval from +2 or -2. That's the uh, rule of the treat and extend treatment. So optimal management of the neovascular AMD allows for the maximized vision gain while minimizing treatment burden. This can be achieved through appropriate management of the retinal fluid. A differentiated approach recognizing the clinical significance of the different fluid compartments is important for optimizing visual outcomes and minimize treatment burden, and implementation and individualized treatment extend regimen that allows for tolerance of stable SRF and is intolerant to IRF may allow patients to achieve the best possible vision. So we all know that aflibercept has been given to more than 25,000 patients, 50 million doses, or more than 1 decade, and the role of the endophthalmitis or IA is very almost nil. So aflibercept provides unsurpassed vision gains with an excellent safety profile across multiple indications, as demonstrated by a RCT and a real-world data. To sum up, we can say that differentiated approach recognizing the clinical significance of the retinal fluid compartments is very much important to optimize visual outcomes and minimize treatment burden. And all this post-hoc analysis and study shows that the IRF is very much negatively impacts visual outcome, whereas SRF is linked to good functional outcomes at baseline and throughout the treatment. And also clinical trials demonstrate that a proactive treatment and extend regimen with aflibercept can maintain vision gains with some residual. Thank you.
Thank you, Dinesh sir, for the wonderful and insightful presentations. So we are ready to take questions from audience. So any doubt or any questions?
So I have one question, Dr. Dinesh. Hi,
Yes.
Dr. Dinesh. I have one small
Hi.
question. So let's say you've given a patient of yours a loading dose of aflibercept, and you've seen that there's been significant improvement in the OCT biomarkers as well as the vision. Vision has improved, and the patient's able to have enough functionality to do his daily work at least. So at the end of those 3 months, the loading dose, let's say there's still some residual SRF left. So not a large amount, small amount, indicating activity perhaps, but there's good functional vision. Would you aim for complete resolution of that SRF and extend, or would you wait and watch at that moment
So
in
the
the
answer of
PRN?
your question is actually you have only given the answer of your question just few minutes back, that nowadays we after the loading dose we depends on the octa actually. Okay, so
Right,
do
right.
the octa, look the network, which kind of it is, open loop or closed loop. So we all know that the closed loop is quite not good for the patient and open loop is okay. So we look at the octa, we see the network, we see and those, and then according to that we need to treat the patient. But few months before only, I have presented one of the presentation of the this aflibercept only. So now they are giving the very much impact on the 5 loading doses actually. If we look at the clinical trials, so more of the clinical trials, each and every drug, they used to say that we used to give the 5 loading doses. Okay, so
Right,
depends on individualized patient, but for your question, it really depends on the octa. We do the octa and then accordingly decide.
right, right. Thank you, Dr. Dinesh. Thank you. Thank you.
Thank you, sir, Dr. Shen. Dr. Mojunda is there. Sir, any questions from your end?
Jodip আছে কি?
I think Rajib sir is not there, but there
Okay.
is a question in the chat box, Rishikesh.
Yeah. So, sir, I think there's one questions. So, doctor is asking, what do you follow in in extension, treat and extension, especially on any criteria specifically you following in your clinical practice to like extending the therapy?
Yeah, so I basically stick to the basic, okay, and give the loading dose, extend the patient, okay,
Mhm.
look for and give them in each every visit in treatment extent you have to give the injection, and afterwards you look for the OCT, you look for the
Mhm.
octa, and
Mhm.
then obviously vision, and as I've said in the PPT, you have to decide whether we should go for the +2 or -2. Simple is that, nothing else.
Okay, great. So, any questions pertaining to that presentations with Dinesh sir?
I think Rishikesh, if there is no question, I think it's good to close the session.
Loading dose in the case of the PCB,
Mhm.
usually 3, but as I said, we look on the this OCT and on Opta, and if possible, nowadays better to give the 5.
Okay.
Right.
And sir, one thing from my end in the practical scenario, do you prefer like any kind of SRF or is completely zero in your clinical practice?
Okay, so frankly speaking, if I come to the practical point of view, which Obik was also was asking, so in the very much initial cases, we usually go for the drying of the OCT. Suppose the patient came, generally with the help of the loading dose or with the help of the 5 doses, usually it becomes dry. Okay, thus this role of usually comes in if the patient is a long-term treatment, then we should have to think whether about. And there is a very clear-cut indication in the fluid study. They have told, look for the less than 200 microns, do the octa. It all depends on the individualized patient and everything. Okay, it's not like that we have to clearly full them clean the SRF and every time. No, it's not like that. Not at all.
Understood.
Right, Savik?
I believe, yeah, exactly. And I believe there's a theory that some amount of uh, SRF is what the word that is used, nutritive. It provides some nutrition. But
Yeah,
again, so that's why, as Dr. Dinesh said, that you have to correlate it with Octa. That's very important. And
very much
also,
important.
over the period, the loading dose, we have to look at the functionality, the vision. So let's say, you have some residual fluid left and the patient has good vision, all other biomarkers seem to be regressing well. Don't immediately go and
Yeah,
inject because you don't want a scarring there. So look at the octa, see if it's necessary, and don't go for rapid resolution if you're going
rapid
for
resolution.
resolution.
Very good.
So that's
In
that's
fact, I
another
like.
thing.
In fact, I like your point that which you are saying to Joyadeep, that don't go for so much hurry actually. Like in the Pacenex, okay, we have to
Mhm.
look for
Right.
everything. In fact, the vision is very much important, not only in the OCT. Okay, the patient don't understand the OCT. Patient needs only the vision, right? So don't go
Exactly.
for so much complete drying. Actually, look, give the time because the anatomical structure uh, coming back to the normal side is very much important along with the vision. It's not like that we free the fluid and become happy so much. No, it's not like
Absolutely.
Absolutely.
Absolutely. So if there's no query further, so we can go back to the last question, sir, from last session. I think I have like asked for that complete regressions or inactivations. What do you prefer with the BCVA? Like if there is BCVA again in
Yeah,
PCV,
as Souvik
yes,
has told that we completely look for everything. We look for the all biomarkers. We look for the visual acuity. And
yes,
nowadays, it's not possible to do the angiography every time like we used to do in our fellowship days. So Octa is a very much important tool actually.
understood.
When I was doing my fellowship in my Girdhars with the help with the under the Girdhars, then after the loading dose, and initially we used to do the DFA and ICG, look for the PCV, confirm the PCV, give the loading dose, okay, and then sir used to do the ICG again, look for the means how much regression of the polyp, and then accordingly he used to treat the patient, okay. But I remember in my fellowship days, sir used to say one thing, that if there is a pinpoint IRF, I still remember. Okay, so you used to ask for the injection. Still little bit of SRF, okay, fine. No, we can wait actually. Okay. So ideally, in the case of the PCV, not only the Octa, you should do the ICG again. Look for the regression of the polyps, and you should actually modify your treatment according to that. But in our case, not so possible in Kolkata. So it depends on the Octa actually. Look for the BBN, how it's regressing, and depends on according to that.
Great. Understood. So thank you so much, sir. Thank you for the wonderful sessions, both of you, and thanks all the audience for joining us and for your precious time. And
Thank you.
we'll
Especially thanks Rishikesh, Dr. Rumta and Dr. Tens for a very insightful discussion. So it's very helpful, I think, for the audience also. Really.
thank you, Dr. Sen. Thank you, Dr.
Thank
Thank you,
Rumta.
thank you very much.
Thank you. Good night.
for this.
Thank you.
Thank you.
Good
Good
night.
night,
sir.
good night. Thank you for this wonderful session to
Thank you,
everyone.
sir.
Thank